have a patient that gets hospitalized, they develop or they get exposed to C. diff while they're in the hospital, right? And so then they become colonized, and then they get something that changes their gut flora and has an impact on their gut flora to allow for C. diff spores to vegetate, and then you end up with active C. diff or clinical C. diff infection. And this old epidemiologic model, I think, was accurate at the time, but when you look at it this way, it helps you prioritize targeted interventions. And so at this point in time, the thought was really that patients were getting C. diff while they were in the hospital, at least getting exposed to it. So that is where infection prevention and control or infection control measures were predominated as far as plans for control, and those things include environmental disinfection, contact precautions, hand hygiene, and of course, because of the issue with antimicrobials, antibiotic stewardship. Well, I kind of preluded this a little bit already, but community-acquired C. diff infection has continued to increase. And at least in the U.S. in 2011, only 24% of all cases of C. diff infection had their onset in the hospital, meaning the majority of these were occurring outside of the hospital setting. This is kind of a fairly repetitive pattern. We've seen this with MRSA and other organisms where things had started in the hospital and then became endemic in the community. Interestingly, in this same review, they outlined that 46.2% of cases now were community associated and did not have any healthcare exposure. So I think we have an increasing reservoir of C. diff infection and C. diff cases outside of the hospital borders, and that's important as we move forward. And it's also important to distinguish community and hospital-acquired cases, not only for kind of the treatment of patients, but also for things like hospital billing and public reporting purposes. All right, well, if you look at the evidence, or at least some of the recent evidence for hospital transmission of C. diff, I think it's interesting and starts to show a little bit of what I'm getting. I'm going to try to move this over just a little bit if I can, without breaking the whole system. I successfully did that. Okay. So we'll just kind of look at it study by study. So the first study in the table, and I've kind of summarized these in this table form, but the first study was a study out of England looking at hospitalized patients who had developed clinically significant diarrhea and had test positive for C. diff. And these are patients that test positive by toxigenic culture. And they assessed these isolates by sequence typing, and they tried to genetically assess them to look at the genetic relatedness, and these were including patients who were symptomatic at the time. And I think one of the interesting findings in this study was that only 25% of cases that were occurring in the hospital were linked to an inpatient source, suggesting, at least genetically, that most of these isolates were coming from somewhere else, not in the hospital. Another study, also in England, looked at patients in the community in the healthcare setting using now whole genome sequencing, which is a little bit of an advanced technique to look at genetic relatedness. These were patients that were symptomatic or had clinically significant diarrhea. And a somewhat similar finding, 19% of cases, of all the cases, had some hospital contact. Excuse me, 19% of all the cases that had hospital contact were genetically related. Again, kind of suggesting that the majority of onset of cases in the hospital setting weren't actually getting those isolates while they were there in the hospital, and they were genetically related maybe to another reservoir. The third study on here was a study in the U.S. that looked at hospitalized patients in the stem cell transplant unit at a tertiary care center. This was a fairly recent publication just earlier this year. This study used sequence typing and screened patients on admission and then weekly during their hospitalization. Again, this is a stem cell transplant unit. Generally would be considered a higher endemic area for C. diff infection. And so they were technically assessing both symptomatic and asymptomatic patients, but a lot of these patients had no symptoms at all. And in this study, 21% of cases they determined that 21% of these cases were nosocomial transmitted, meaning the rest of the 79% they suggested were from another source, or they didn't develop this infection while they're there in the hospital. I think some other take-home points from that study were that 26% of patients were positive at the time of their admission, which is a high number, and 75% of colonized patients later developed C. diff infection with an identical strain to the one that they were colonized with, again suggesting that asymptomatic colonization is a significant risk factor for the development of disease and may be the at least in some of these studies, may suggest that the majority of cases that occur in the hospital are not from a strain that they got while they were there, but from a strain that they had before they came in. So let's talk more about asymptomatic colonization then in C. diff. This was a review in American Journal of Gastroenterology last year that reviewed previous studies that tried to assess the asymptomatic colonization rates of C. diff upon hospital admission. And as you can see over time, is that this has increased. This has increased pretty dramatically. At least some studies, I just mentioned the last one, but even some studies here suggest that almost 24 or 25% of patients entering the hospital are already colonized with C. diff. And that goes along with, obviously, the increasing community onset rates of C. diff as well. Well, this study also looked at the relative risk of infection in patients that were asymptomatically colonized compared to those that were not. And really, to no surprise, there was a significant risk there, almost 6 times that of the asymptomatic colonized patients for going on to develop C. diff infection. And that's a pretty good I-square value, so it's a low heterogeneity study. All right, so then let's take another look back at our epidemiologic model using some of that information that we just reviewed. This was the previous model that we looked at. I think it's a little bit outdated now, and so let's kind of reverse this, or let's redo this a little bit. So we think probably C. diff exposure already happened to the patient before they make it into the hospital. There's still some horizontal transmission of C. diff while they're there. It certainly has not gone away, and I don't want to advocate for no longer doing infection control practices, but I think it may be less than what we previously realized, at least a number of years ago. Antimicrobials is still a big deal, a big risk factor for the development of infection. But when we do this, when we make a new model, we kind of reprioritize our targeted interventions, and we're able to reprioritize these things. And I think what we see is that antibiotic stewardship comes really to the forefront, as does appropriate testing, and then infection control is still an important strategy as part of a bundle type approach. But if we're just focusing on infection control initiatives, we're missing the majority of the ability to impact C. diff infection. I put on here asymptomatic screening. I put a big question mark on there. This is an area that's somewhat controversial. I don't really want to get into it too much, but there is some issues or some debate right now about should we be screening patients on admission for C. diff and doing active screening and contact precautions like we do for MRSA and other things. I think that's still yet to be determined if that's helpful, but at least it suggests that there may be a significant amount of exposure into the environment from asymptomatic patients. All right, so we finished the epi. Let's talk about testing a little bit, and I'll start by looking at a case. So this is a 65-year-old, we'll call him a white male, who is admitted for seizure. He has a known prior history of C. diff 3 months prior to this current admission. He's afebrile, his white count 6.7, his creatinine 0.9, he's in no acute distress. He had a KUV done for Dopop tube placement confirmation, which showed an increased stool burden. Upon review of the flow sheet by, let's say, the infection preventionist nurse, there was documented 1 hard bowel movement on hospital day 2. The patient received a molasses enema on times 2 on hospital day 2, a lactulose enema times 1 on hospital day 3, polyethylene glycol powder, and Senna syrup as well on each hospital day since his admission. On hospital day 3, he developed liquid stool, as one might expect, and a C. diff PCR was ordered. That C. diff PCR was obtained on hospital day 4. That was positive. He was afebrile with no acute distress. He denied any abdominal pain, and his white count was technically normal at 8.2. He was prescribed Flagyl for 14 days. I would really like to say this is an uncommon scenario, but I think it happens actually more frequently than we realize, and it certainly happens at our institution. I know it's happening in other institutions as well. And the kicker here, or at least the side note here, is that per CDC NHSN surveillance criteria, this case has been reported to the government as a hospital onset C. diff lab ID event and goes into effect things like pay for performance measures and HAC scores, which is part of the CMS and patient perspective penalty system. All right, well, let's look at specifically some diagnostic targets and ways to diagnose C. diff. I think we've all kind of gotten very accustomed to the PCR testing, but we should probably have an idea of what else is available. So these diagnostic targets are listed from top to bottom in order of increasing specificity. So tests that specifically look for the presence of C. diff organism would be an antigen-based test that looks for glutamate dehydrogenase, or GDH. And we'll kind of talk about each one of these tests here in a second. There's tests that look for the presence of C. diff toxin genes, and it's toxigenic culture, which actually is considered a gold standard but is not readily available. And then, of course, we have our PCR test. And I want to make sure I differentiate what the PCR test actually tests for. This is testing for the presence of toxin gene, not the presence of foreign toxin. So toxin gene means that a positive PCR test means that patient has the presence of toxigenic C. diff. It doesn't tell you actually anything about what it's doing there or if it's producing any toxin. And then the highest specificity test, or at least target for the active disease process, would be the C. diff toxins. And that would include the antigen-based test for toxin A and B, as well as the C. difficile cytotoxin neutralization assay. If you look at these tests individually, there's differing sensitivity and specificities with each one. The top two are kind of historically considered to be gold standards, although their availabilities are quite limited. The GDH test, which is listed as number 3 there, or the third one down. Let me see if I can figure out how to, I don't want to hit any wrong button, but how do I do the, okay, success. So if you look at the GDH test, and I'll kind of walk through this in a second, but the GDH test can be used for screening because it is a sensitive test, but it does lack in specificity. So the GDH test must be confirmed with follow-up testing for the presence of toxin if you're going to use it clinically. It can have false positives, so it's looking for C. diff organism. It can also be positive in other Clostridial species, so it does have some limitation there, but it is a sensitive test that can be used for screening. I mentioned the antigen for toxin testing. Here it is not a very sensitive test, or not as sensitive, and so we could miss cases if we just use that alone, which is its big drawback, but it is a specific test. And if you look at PCR testing, it is, I mean, its hallmark is its sensitivity. It's a very sensitive test. It does have high specificity when you're using the gold standard for the presence of the organism. But you can have false positive situations for clinical disease states, like I kind of walked through with our case, where you have patients that are on other things that cause diarrhea. You get a PCR test and it's positive. Then you have 2-step and 3-step algorithms used as well, which are fairly available, and when you use them appropriately, they can be sensitive and specific. Now, obviously, the advantage of the PCR test in most places is turnaround time. I think most hospitals that have gone away from using toxin antigen tests, if you wanted to do those would probably be send-outs, and so you would be limited somewhat in rapid diagnostics. So let's say you did want to use a 2- or 3-step algorithm. This is a look at that. So you could start with the glutamate dehydrogenase test, which actually detects the presence of C. diff antigen. If it's negative, it is a sensitive enough test that typically, with most cases, say you don't have C. diff there. If it's positive, then you would follow it up with a foreign toxin test or antigen-based test there. And in some cases, if it's negative but your pretest likelihood you think is still high, then you can go forward and go on with PCR-based testing. So those are 2-step and 3-step algorithms. There are still some institutions that use this. I think it's important to know this because I do know of a couple of institutions that have gone back to this, actually, that have gone from PCR tests to this method of testing to try to more accurately determine what is causing clinical disease. Okay, so there can be disagreement between diagnostic tests, and that has impacts on the clinical decision making and, of course, on public reporting as well. Which is a role that I have and an interest that I have also. So let's look at this. Let's look at the potential for overdiagnosis of C. diff infection in the molecular test era. And so this was a study out of UC Davis published last year that was a prospective single-center observational cohort study. And what they did for a period of time, they ended up having 1,416 hospitalized patients enrolled in their study. But what they did is they combined both toxin testing and PCR testing on everybody that was getting a test for C. diff that was in the hospital for at least 72 hours. And then they went back and grouped those patients into 3 groups. A group that was toxin positive, PCR positive, a group that was toxin negative, PCR positive, and then a third group that was toxin negative, PCR negative, so completely negative. again, the toxin, and this will get confusing. I'll be saying toxin and PCR a lot here in the next few minutes, but the toxin-positive PCR group, just to remind you, these are patients that PCR positive, right? So they have the presence of toxin gene and toxin antigen positive, so they also have the presence of formed toxin. The second group, again, toxin negative, so they don't have the presence of formed toxin, at least it wasn't positive, but they did have the presence of toxin gene, suggesting it wasn't active or may not have been active. Then they looked at these three groups and compared outcomes with duration of diarrhea during their treatment, the rate of related complications, and C. diff infection-related death within 30 days. And we'll kind of go through the results a little bit. So this was specifically, first of all, looking at the time to resolution of diarrhea by test group. And what they saw was that basically the toxin-negative groups behaved the same and separately from the toxin-positive groups. So it didn't necessarily matter if you were PCR positive or not. What mattered, at least in the time to resolution of diarrhea, was whether or not you had formed toxin. Then when they compared statistically the toxin-positive group with the toxin-negative group, there was a significant difference in the risk of ongoing diarrhea at 15 days. Looking at some of their other outcomes, and I'll go through these fairly quickly, but as it related to C. diff-related complication or death, they really saw the same thing. So the toxin-negative groups behaved very similarly and were statistically significant than the toxin-positive groups, even if they were PCR positive or PCR negative. It didn't necessarily matter. Yeah, so the PCR positive, toxin-positive group was less likely to be retested. Kind of makes sense throughout that whole study. And it also wasn't like the toxin-negative PCR positive group was getting treated a lot. Only 40.7% of patients in this category were treated compared to 100% in this category. I think it's also interesting to look at the numbers. So there was 131 patients that were toxin-positive, PCR positive, but 162 that were toxin-negative, PCR positive. So more that actually didn't have formed toxin than did, and suggested that that was maybe more common than we might think. And the same here for treatment at 15 to 30 days. So the author's conclusions was that exclusive reliance on molecular tests for C. diff diagnosis is likely to result in overdiagnosis, unnecessary treatment, and increased healthcare cost. And they went on to conclude that, at least based on the results of their studies and their numbers, that up to 50% of patients with a positive molecular test result for C. difficile do not experience adverse events without treatment and do not need treatment for their quote-unquote infection. And so this was actually a study that Edina was involved in, I think. This came out of Johns Hopkins. This was a evaluation of nursing education and stewardship interventions on C. diff testing. So really trying to get to the heart of testing appropriate specimens from the beginning or from the onset. And she could probably speak to this more, but basically what they were able to find was that after nursing education and their interventions, they were able to increase the number of patients that were positive by PCR. They were able to increase the number of those patients that had clinically significant diarrhea. They were able to decrease the number of patients that were on laxatives within 48 hours of their test. I saw you shaking your head a little bit earlier when I was mentioning it, so it is a big, I think, a wider problem maybe than we initially realized. In fact, at the baseline period here, 50% of all their patients were getting laxatives within 48 hours, and with intervention, 19%. And that 50% is very similar to our numbers as well. And then they were able to increase the appropriate therapy for severe infections, so fairly low numbers, but by targeting interventions to try to increase appropriate testing, they were able to show that they could have an impact, at least in that setting. So I want to talk a little bit about our internal testing algorithm that was developed a little bit ago, and this is for physicians, but it starts with a concern for C. diff infection, as you might expect. And the first question that really should be asked is, does the patient have clinically significant diarrhea? And so, you know, a lot of times as a physician, we're not necessarily at the bedside, or we're not going to be at the bedside all day. The nurse is. We might be in there for 10 minutes. They have a loose bowel movement, but actually the nurse knows that's the first loose bowel movement they've had since they've been there. We will reflexively order a C. diff test just because we have this capability to order this thing, and we're going to do it. And so, but that's really not right. I mean, the first question is the diarrhea clinically significant? And if it's not, we really shouldn't be testing patients. Now, certainly if there's concern for ileus or toxic megacolon, it's a little bit of a different scenario. But if there is clinically significant diarrhea, then, and this is defined as 3 or more loose or liquid stools in a 24-hour period, by the way. If there is clinically significant diarrhea, the next question is, does the patient have signs or symptoms of infection? Fever, elevated white count, abdominal discomfort. If the answer is no, then we should probably investigate alternative causes first. It doesn't mean don't order the test, but it means we should take a step back and say, could there be other causes of this? Oh my gosh, this patient's been on Miralax every day for the last week and a half. Let's stop that and see what happens. Of course, if they do have those signs and symptoms, then we do recommend c.diff testing. All right, so this is an example of our nursing education. One of the slides from one of our IPs that did some of our nursing education. So we've instituted the Bristol Stool Scale. So if you guys pay attention, this went out fairly recently, so if you guys pay attention to the nursing flow sheets, you'll see this numbered system. I don't know if it has the foodstuffs in the actual chart, but it always gives a good graphic. And we're really focusing on stools that meet criteria for type 5, 6, or 7 to be sent to the lab. And we're really focusing that formed stools should not be sent. And so similar to the physician algorithm, there's a nursing algorithm that really follows a very similar process, but then ultimately refers them to the Bristol Stool Scale on whether or not the specimen is appropriate for testing in the follow-up visit if it's not. So I think no good c.diff test is appropriate without a picture of stool. So here we go. This is a so-called stick test. So most of the currently, or all the currently available c.diff PCR standalone tests are FDA approved for testing on unformed stools. And most laboratories do some assessment to determine whether or not it's formed or not. And so technically, formed stools are not appropriate for testing, and they're not FDA approved to be tested for. So our laboratory, like many laboratories, do what's called the stick test. So they'll stick the stick in the middle, and if it stands up, it's rejected as it's too firm for testing. All right, we're in the home stretch here, so we'll talk just a little bit about antibiotic stewardship, although it's hopefully been the overwhelming message throughout the last few slides. But there's a variety of studies out there that have looked at the impact of antibiotic stewardship programs on c. diff infection and c. diff incidence. This is just a review and meta-analysis of some of those studies. I think across the board it's interesting to note that, at least in this review, stewardship programs were associated with a 52% decrease incidence of c. diff infection. I guess I should note it's a fairly high heterogeneity review, but significant impact across the board. This was just some more of their data, and I just wanted to highlight this column. Just kind of when they broke it down by subset analysis, it was stewardship programs were really impactful across all types of interventions, locations, etc. All right, so conclusions then. So increasing C. diff care, it stresses the importance of antibiotic stewardship, stresses the importance of appropriate testing, and it continues to stress the importance of infection control measures. We need to just be cautious that molecular tests can overdiagnose C. diff infection if we're not thinking about the patient and taking their clinical characteristic into consideration. The most important and most modifiable risk factor for C. diff infection, I truly believe, is antibiotic exposure. And antibiotic stewardship programs can have a significant impact on the development of infection. And with that, I'll stop there. Do we do questions or not? That's fine. Anybody? Yeah.
If anyone has any questions at the end, we'll save questions for the end of both speaker presentations.
Okay, can everyone hear me? No? Oh, for the remote side, okay. So I need to check if everyone can hear me remotely. Okay, can you hear me back there? Okay, great. So thank you very much for inviting me to speak to you here today, to organizing committee, and for those of you who are here at the UK site. My talk is going to focus on rapid diagnostics tests from the blood cultures and antimicrobial stewardship. These are my disclosures. They're not related to this particular presentation. And I'm going to skip going through the objectives since we are I started this presentation a little bit late. In 2004, IDSA launched a campaign, Bed Bugs, No Drugs, which most of you are probably familiar with. And the goal of that campaign was to raise awareness of antimicrobial resistance, as well as to provide incentives for new drugs development, as the pipeline for new drugs was pretty dry at the time. Within that campaign, there was also a plug to establish similar statutory incentives for development of rapid diagnostics to quickly identify targeted pathogens. So over the last decade, I think the IDSA campaign has been pretty successful raising awareness of antimicrobial resistance. New drug development, we have a few drugs, but certainly we're not where we really want to be. But the growth of rapid diagnostics have been moving much faster rate than I think we expected. There are a number of tests that have become available over the last decade for use on blood cultures and a variety of other specimens. And there are also many tests that are in development that will probably be available in the near future. However, IDSA in 2013 wrote a IDSA public policy statement. At that point, they felt that those tests yet are available, but they were not really that well utilized in clinical practice. So the call of this campaign was to develop research to evaluate impact of those rapid diagnostic assays on patient outcome and healthcare, but also to figure out some better ways to integrate those rapid diagnostic assays into clinical practice. Today we use those rapid diagnostic assays in large academic medical centers, but we're probably not using them in many smaller community hospitals that are perhaps resource limited. Those rapid diagnostics do have a potential to truly revolutionize patient care and change how we think about infectious diseases. We do have rapid diagnostics that can help us identify quickly resistant organisms and differentiate some of the specific pathogens and provide directed therapy early on. But there are also rapid diagnostic assays that are in development that perhaps one day will be able to tell us if the patient has infection at the sign and symptoms of the patient presents. And also distinguish if that's a viral, bacterial, but also do susceptibilities within a few hours after diagnosis. And perhaps some of those tests will be available at point of care, although some of those tests will probably still remain to be performed in microbiology laboratory. There are also conferences now dedicated purely to rapid diagnostic assays. Usually researchers, drug industry, as well as the clinicians presenting new novel technologies and kind of collaborating how do we better integrate those technologies into a patient care. Rapid diagnostic assays that are currently available can dramatically shorten time to pathogen identification to only a few hours compared to traditional methods that may have taken up to 48 to 72 hours. In general, when we think about those technology, at least for blood cultures, we divide them into two groups. Technologies that can be performed on positive blood cultures, meaning the patient has to have a positive blood cultures, and then those technologies can be performed. And those that can be performed directly on a blood, meaning that you can run those tests before the blood cultures turn positive. So some of the assays on whole blood that have been available and have been used more broadly in Europe. And there's only one that has been so far cleared in the United States, which is T2 for Candida species. We still don't know what their clinical and economic impacts are on patient care. We have a lot of data about their sensitivity and specificity. One of those examples is light cycler or septifast, and this technology can detect anywhere from 3 to 30 colony-forming units of 25 most common pathogens, as well as the Candida species and aspergillosis. A turnaround time is about 6 hours, and the sensitivity and specificity of this test has been variable from study to study. So I think more research is needed, at least for this technology. And then T2 magnetic resonance, at least has a recent publication in CID, and this test can detect as low as 1 CFU colony of a Candida species from blood, so they can detect 5 Candida species and have pretty good sensitivity and specificity. And mean time to species detection and identification was about 4.4 hours. They also do have, or they're working on a technology that can also identify bacterial pathogens in several other species. Technologies that have been used in positive blood cultures that I will discuss, some of the studies are listed here. As you can see, they all have very long names, so I will say them this time and refer to acronyms afterwards. So one of the oldest technology is peptide nucleic acid fluorescence in situ hybridization, or PNA FISH. There are also multiplex PCRs. Some of them are pathogen specific, so they can, for example, distinguish staph aureus from coag-negative staph, and other ones are broad-based that can identify several pathogens from blood. There are also broad-based multiplex nucleic acid assays, such as Varigene gram-positive and gram-negative panel. And then lastly, there's a matrix-assisted laser desorption ionization time-of-flight mass spectrometry, or what we would usually refer to as MALDI. This technology can also be performed directly on a positive blood cultures, meaning that you don't need to have a gram stain performed. You can do it directly on blood, and some labs do that, while the others do it after the blood cultures turn positive. And this technology can also be used not only in blood cultures, but pretty much all specimens. So here are some of the rapid diagnostic assays that have been evaluated in clinical practice. It gives you an idea how many pathogens they can identify. PNA FISH has several different probes that can distinguish different organisms, for example, staph aureus from coag-negative staph, E. faecalis from Enterococcus species, E. coli, Clade pneumo, and Pseudomonas aeruginosa probe, as well as the 5 Candida species. At this time, they don't have FDA clear resistance marker, but they are working on, or at least have a resistance marker from MACA, which distinguishes MRSA from MSSA. There's also multiplex PCR that can differentiate staph aureus from coagulase-negative staph, and also have a resistance markers. And there are several broad-based technologies, which include nucleic acid macroarray. This is Varigene, that has a gram-positive and gram-negative, and has several species and several organisms that can identify, as well as several resistance markers. And then there's a film array that can identify gram-positives, gram-negatives, as well as the yeast and several resistance markers. And then MALDI can identify a large number of species, but at this time cannot identify resistance markers. As you can see, most of these tests can be performed very quickly. Some tests can take up to 20 minutes to several hours. So this is the time the test is performed. However, many institutions, when we implement those tests, it takes much longer to report the results because we tend to batch them and do them after several hours. Here's some of sensitivity and specificity of selected rapid diagnostic assays. As you can see, they're pretty sensitive and they're pretty specific, in high 90s and 100%. For a couple of them that do organism identification as well as the resistance markers, again, pretty high sensitivity and specificity. You see some ranges, and there are some differences between different organisms. So for example, a lot of these technologies are really good and very sensitive and specific for staph aureus, MSSA and MRSA, but may not be so good for Enterococcus with NA and MB genes. So you see a broad range because these are mostly for all of the organisms. So before we talk about some of the data, I wanted to kind of just walk you back through comparison of those rapid diagnostics into traditional cultures. So usually when we suspect infections, I will send the blood cultures and then start patients on some type of empiric therapy. And so that might take 48 hours or so, sometimes several hours, sometimes up to 48 hours for blood cultures to turn positive. This is highly dependent on the organism, burden of the pathogens in the patient's blood, and whether or not they received antibiotics prior to that. So once the blood cultures turn positive, we'll perform gram stain, and then several other tests can be performed to identify the organism. And once you identify the organisms, then you ended up with susceptibility. So this time from the positive blood culture and gram stain with traditional cultures can take up to 48 to 96 hours. And again, this is highly dependent on the pathogen. With rapid diagnostics, you still need the growth of the organisms, at least the ones that are currently available, with the exception of a few. And then those rapid diagnostics can quickly identify some organisms. So for example, if you have a Staph aureus or GPC growing clusters, within 3 hours you might learn the patient has MRSA or MSSA. So for some of those you don't need susceptibility testing, you can adjust the therapy, while for the others you may have like MALDI, you'll have ID, but then the susceptibility would still need to be set up, although that time is still shorter than compared to traditional cultures. And then for whole blood, this is where dose tests would be different, is before the blood cultures turn positive. So again, identified pathogens, particularly for Candida, for example, before your blood cultures turn positive. So timing of appropriate therapy is extremely important. Most of you are familiar with the Kumar study that suggested that patients who don't receive appropriate therapy or effective therapy in timely manner have a higher risk of mortality. In this study, about 80% of the patient has survived if they received appropriate antibiotic therapy within first hour after the onset of sepsis, which in this case demonstrated by onset of hypertension. So for every delay, for every hour up to 6 hours, there was increase in mortality by 7.6%. So getting patients started who are septic and critically ill or bacteremic is really important in timely manner, and hours do matter. So what is the role of antimicrobial stewardship program in rapid diagnostics? Antimicrobial stewardship team can help translate the results of rapid diagnostic assays to frontline clinicians. Those tests are available, and many clinicians have been in practice and did not learn about those rapid diagnostic tests in microbiology lab. So as a stewardship people, it's our job or responsibility to help translate those tests from our micro lab to a frontline clinician. We can develop algorithm and guidelines how clinicians should respond to those tests, assist teams with optimizing and de-escalating therapy. And then we also need to demonstrate benefits of those rapid diagnostic assays. They are expensive. A lot more expensive than your traditional cultures. So in order for us to add those new tests, your microbiology laboratory is not going to be happy about it because they have to find a space to put those new technology. They have to order the tests to perform. And so we have to some way justify that we're not just implementing these tests and reporting the results. We need to do something about those results. And so this is where stewardship team can collect some data and help justify to either bring new technologies or keep the current technologies that you have in your micro lab. In collaboration with microbiology laboratory, we can also select the best tests that fit our institution needs. So it depends on your budget, what pathogens are the problem. If your institution that doesn't have a lot of multi-drug resistant organisms, you need broad-based Verigene test or another test that can pick up a lot of resistance markers if you don't have them, because you have to perform them on all gram-negative positive blood cultures. And the same way goes for Staph aureus. Perhaps you need to pick a test that only tells you or it focuses on MRSA or MSSA or coag-negative staph. And depending on what resources you have to do those interventions. And then we also help implement or develop a process for implementation of those tests. So just to show you complexity, how some of those broad-based rapid diagnostic can be, at our institution we implemented Verigene, which is nucleic acid microarray. And as you can see here, the test is performed on positive blood cultures. So when you have a gram-positive cocci where there's clusters or chains, that test can be performed. And you have ability to know if it's a Staph aureus, if it's MRSA, if it's Enterococcus, if it's VRE or not VRE, Streptococcus, several species, and a subgroup of species. And for Staph epidermis, you can also do MAC-A. So at our institution, we knew that if we just report a MAC-A positive, clinicians would not know exactly what that means. So we translated to say, this is MRSA or MSSA. We also decided not to report results for Staph epidermis or MRSC, because at our institution we just reported as coagulase negative Staph species, and we have seen through our clinical practice that sometimes people get confused with MRSC and MRSA. So we didn't really want people to be treating someone for 6 weeks for MRSC, which is coag negative Staph, and not necessarily MRSA. We also chose not to run this test on Listeria species because that's a gram-positive rod, and then we have to do that on all gram-positive rods unless we suspect that patient might actually have Listeria meningitis, for example, so we may choose to perform that test. We developed an algorithm, and so after providing education and implementing this test, we pretty much specified what drug should they use based on results. So for example, if they had MSSA, we demonstrated some of the susceptibilities here for each buck, told them what's our preferred therapy, and provided alternative therapy if the patient had a penicillin allergies. And so then our clinicians, our clinical pharmacists, and our stewardship team follow this kind of algorithm to provide recommendations for action after those tests were available. So can those rapid diagnostic assay improve patient outcome? I'm going to talk about a different organism and just discuss several selected studies. So here's our 2 rapid diagnostic assays that evaluated clinical impact of rapid PCR on patients who had a Staph aureus bacteremia. Both of these studies were before and after the implementation of rapid diagnostic assays. The first study by our colleague used PCR plus antimicrobial stewardship intervention compared with control, which is your traditional pulse transmissibility. And in this study, they were able to decrease optimal therapy, usually oxalate, from 3.6 days to 2 days. And that was significantly different. However, they really were not able to significantly impact the treatment. As you can imagine, most of these patients will be on isomycin or some MRSA agent. Another study by colleagues did not utilize intervention, just results. And as you can see, it's not any difference in talking to therapists. Clinicians know those results. And there was no retaliated benefit of each of studies. With respect to Enterococcus bacteremia, there were also 2 studies that utilized antimicrobial stewardship intervention. The first study by Forster colleagues utilized finished blood antimicrobial stewardship. And this is one of the first studies that evaluated the impact of rapid diagnostics. And in this study, they showed that in time to optimal therapy for patients who had Enterococcus species for 3.1 days to 8.3 days. And that's mainly because these patients had actually VRE. So they were able to keep those patients on appropriate antimicrobial therapy, televizolone, daptomycin. But they didn't see any difference for Enterococcus faecalis, as most of these patients were already on appropriate therapy. The second study was by some colleagues who utilized Verigene, and again, they did antimicrobial stewardship intervention, and they saw the same benefit for patients who had vancomycin-resistant Enterococcus or VRE, but not significant benefit for patients who had E. faecalis. There was mortality benefit observed in small subsets of the patients in Forster and colleagues study, and that's again mainly because of the enterococcus bacteremia that was secondary to VRE. However, the study has a lot of limitations, as those patients were BMT and solid organ transplant, so there might be other reasons why their mortality was significant, but at the least they were able to improve their time to optimal therapy. So what about coagulase-negative staph? Most studies that looked at coagulase-negative staph bacteremia looked at discontinuation of unnecessary vancomycin therapy. There are several studies that evaluated that, and they were able to show 1 to 2 days decrease in time to discontinuation of vancomycin in few studies. Studies that utilize antimicrobial stewardship intervention or some type of notification saw the benefit, but those who didn't really see any benefit. Again, has to do with the translation of the results to clinicians. Gram-negative bacteremia. So there are 3 studies that evaluated MALDI-TOF plus antimicrobial stewardship interventions and compared that to control. All of the studies were before and after, again, of implementation with active antimicrobial stewardship interventions. The primary outcomes that were looked at in those studies was time to active therapy and then also time to optimal therapy. So time to active therapy was giving patients an antibiotic that will have activity against the pathogen. The time to optimal therapy was variable between the study, but usually meant de-escalation of vancomycin, de-escalation of anti-pseudomonal agent if the patient didn't have Pseudomonas as identifying pathogen. And so in the first study by Perez and colleagues that looked at only gram-negative bacteremia, they showed decrease in time to active therapy by 38 hours. And time to optimal therapy was decreased by 46 hours. So both of these were significantly different. They also looked at all-cause mortality, and they didn't see the difference. The study by Hung and colleague looked at gram-negative rods, gram-positive cocci, and yeast in blood. And they were also able to decrease time to active therapy by 9.7 hours and time to optimal therapy by 43 hours. In this study, they saw significant reduction in mortality, and that's probably related to getting patients on appropriate therapy sooner, that perhaps it does make a difference in mortality. And the second study was done by, our third study was done by Perez and colleagues, and they looked at only multi-drug resistant organism. In this case, it was mostly ESBLs and some of the CREs. And again, in that study, they were able to decrease time to active therapy by 57 hours, and time to optimal therapy was similar to that. So the time that they're modifying therapy to give appropriate therapy, they were able to de-escalate inappropriate antimicrobial therapy. And again, in this study, they show mortality benefit. Again, it has to do with giving patients appropriate therapy in timely manner. So this is a study that we did in our institution. We did a randomized trial that evaluated impact of PNA fish on clinical outcomes of the patients who had a gram-positive cocci in chains. And so PNA fish could tell you if it's eficalis, non-eficalis. At our institution, that was enterococcus, and that was mainly VRE, and the streptococcus. And we had the 2 arms. One was PNA fish plus notification by laboratory technician who told them, you have an eficalis, it's 99% susceptible to ampicillin, and kind of ended there. Or told them that they have enterococcus and most likely is going to be VRE. And then basically there was no other suggestions in therapy. In our study, we did not see any difference in time to optimal therapy, time to appropriate therapy, in-hospital mortality, or infection-related length of stay. So at least in our institution, without antimicrobial stewardship, letting people know that there is some rapid diagnostic tests doesn't really mean much because they don't really do anything about that. Many institutions now utilize combination of rapid diagnostic assay. This was a randomized controlled trial evaluating outcomes associated with rapid multiplex PCR, which was the film array, detecting bacteria and fungi and several resistance markers. In this study, the 3 arms. So at the baseline at this institution, everybody was getting MALDI-TOF. So their baseline was already much further advanced than perhaps in some of the other studies that didn't utilize any rapid diagnostic assays. And they also did rapid tests for MRSA. So on top of those two tests, they also implemented film array and did randomized control, just a rapid PCR film array, and then the third group included antimicrobial stewardship intervention. Several outcomes that they looked included duration of broad-spectrum antibiotics, and in this study, they were able to decrease piptazo, for example, is one of the broad-spectrum antibiotics, in both arms with and without antimicrobial stewardship interventions. Duration of narrow-spectrum beta-lactams, which in this case included oxacillin and cefazolin, was significantly longer in both PCR and stewardship intervention. Time to de-escalation was not significantly different between rapid diagnostics alone and control, but adding stewardship intervention was helpful. So they would have de-escalated, but it just took a little longer without antimicrobial stewardship intervention to reminding them that they can go ahead and de-escalate. And then treatment of contaminant was also decreased with both rapid diagnostics alone as well as the stewardship interventions. In this study, there was no difference in mortality, length of stay, or cost between three arms. So is combination of rapid diagnostic assays and antimicrobial stewardship / education sustainable? So at our institution, we wanted to test this theory. We were wondering, do we have to continuously, if we implement new rapid diagnostics and we do stewardship intervention, do we have to continue to do this every day? Or can we educate for some period of time and then let frontline clinicians be comfortable with those tests and don't have to be reminded all the time to change therapy? So we did control, which is our traditional testing and identification. The only rapid diagnostic at the time that we utilized for blood culture was PNA FISH for enterococcus. And then our intervention was Verogen blood gram-positive panel for blood cultures, and then antimicrobial stewardship, and then post-intervention period alone. We did all of these for 7 months. So we did 7 months of interventions, and after 7 months, we just stopped. The results I have here are for MSSA. So our time to optimal therapy, which we used from the gram stain, in control was 49 hours. During intervention period, we were able to decrease that to 13 hours. So 13 hours after the gram-positive coccidiosis was identified, they were able to get on cefazolin or oxacillin, depending on the patient. That was the stain in post-intervention period. The p-values on the right are comparing the intervention and control, but they were not as fast as we are with antimicrobial stewardship intervention changing those patients to optimal therapy. And we did this on the weekdays, weeknights, as well as the weekends. So this probably has to do with them having a reminder the moment these gram-positive, the test is available, that it's okay to switch to oxacillin. So they still did better compared to the control, but not as good as when we had antimicrobial stewardship interventions. We did not see the difference in infection-related length of stay or mortality, although at least based on the percentage, looks like mortality decreased, but it was not statistically significant. The other pathogen that we were interested was a coag-negative staph, and we're evaluating impact on the other organisms. But we noted, as you can see in our institution, we have about 50% or more contaminants from coagulase-negative staph. So this test is very beneficial for us because this would be lots of unnecessary treatment. We looked at time to discontinuation for only contaminants, and we actually did not see statistically significant difference between control and intervention. But surprisingly, in post-intervention period, there was a significant difference. And I think this has to do with clinicians being comfortable with the test. So once they get used to that test, it may take more than 7 months, and trust the test, they're a lot more comfortable afterwards to make a change. So at this time, if the patient is clinically stable, most of our clinicians would not give any vancomycin, knowing the results will be available within the next 3 hours. So they're a lot more comfortable than perhaps when we just implemented tests. Because to some, this still doesn't feel real to you getting results within a few hours to tell you if it's MRSA or MSSA or coagulase-negative staph. And again, here we did not see significant difference with respect to duration of the hospital. So a lot of these tests have been performed in academic medical centers, places that have pretty robust and active antimicrobial stewardship programs, but can they be really done in a community hospital? This was a study that was published recently looking at rapid diagnostic assays at 2 community hospitals. They were both about 240, 230 bed hospitals, and they're associated with a larger academic medical center. So again, they looked at MALDI-TOF plus antimicrobial stewardship intervention, and their primary outcome was the adjustment of antimicrobial therapy. So that included de-escalation of broad-spectrum agents, escalation of the agents based on the results, dosing modification, and discontinuation of necessary therapy, meaning discontinuation of vancomycin if the patient had gram-negative, or discontinuation of gram-negative coverage if patients had MRSA. So they were able to have more therapy adjustment with the antimicrobial stewardship interventions plus MALDI-TOF, but there is no difference with respect to length of stay and mortality. So the community hospitals can also benefit from those rapid diagnostic assays with some stewardship interventions. So what about length of stay and healthcare costs? Can those rapid diagnostics impact have there? There's several studies I've selected here that all have decrease in length of hospital stay. Some were significant. First study was by Sengos and colleagues that I presented earlier. They were able to decrease length of stay by 22 days, and they had a significant cost reduction. And this institution seemed to be using empirically daptomycin, for example, and linezolid for patients who have enterococcus because they were concerned for VRE. So this helped them de-escalate early and perhaps save some empiric therapy with those expensive agents. And then 2 other studies were also able to decrease duration of hospital stay for both gram-negative bacteremia as well as multi-drug gram-negative resistant organisms, and had a significant reduction in hospital cost reduction per patient. And a lot of those were combinations of decreased length of hospital stay and the cost of the drugs as well as the test. So what are some of the benefits of rapid diagnostic assays? They can shorten time to optimal and effective therapy. They can de-escalate from broad-spectrum antibiotics or shorten the time to de-escalation. They can also help decrease use of unnecessary antibiotics. The clinical benefits are organism-specific. So most of the benefits that we have seen were for MSSA, Enterococcus faecium, and gram-negatives. They do have a potential to decrease length of hospital stay, which is also organism and institution specific. And early identification of resistant organism perhaps can also help with isolation early. And they can potentially result in significant cost savings. Some of the drawbacks of those rapid diagnostic assays is that they're really not that valuable if you do nothing about them. If you just report the results, you're not really benefiting the patients, and you're not saving any money, at least for your institution or to the patients. They do require, based on at least reported literature so far, a strong antimicrobial stewardship support. They're more expensive than traditional culture and susceptibility testing, so there's a cost of getting the machine or instrument into your lab, finding a space for that machine or instrument, and then there is additional test of supplies that you do per patient. There are also, like I said, additional space lab needed, and some of the assays are more technically complex to perform, so some of those tests may require some additional training for technicians to perform them, make sure that they're done accurately. But as we go through time, those technologies are also improving, and those tests are becoming easier to perform. So in summary, rapid diagnostic assays can shorten time to optimal and effective therapy in patients with bacteremia. With rapid diagnostic de-escalation of broad-spectrum antibiotics to more targeted therapy can actually occur now at 24 hours as opposed to traditional 48 to 72 hours or even less. Use of those rapid diagnostic tests may result in some cost savings to the institution, to the individual patient, but also to the hospital. They're most effective when they're combined with antimicrobial stewardship interventions. And hospitals should select assays based on their patient population, the prevalent pathogen, the cost, presence of antimicrobial stewardship. And that concludes my presentation. Thank you. If you wanna.
If anyone has any questions for either Dr. Avdic or Dr. Forster, and for our remote sites, if you want to type in your questions into the GoToMeeting, we also have some questions on Twitter. So our first Twitter question is, are there any rapid diagnostic tests being used for CSF samples? If not, is this currently an area of focus for researchers?
I'm personally not aware of particular tests, but I know that there are some tests that are in development. I don't know if any of them are FDA cleared yet for use, but I know there are a couple of companies that are looking at this CSF specific test. I don't know if anybody else in the audience knows the answer.
Anyone have any questions here?
Our laboratory director has looked at a multiplex PCR test and produced CSF. I'm not sure what the time frame is, but I know like it's going on.
There's one right here. I can't see.
This question is for you. You'll have to repeat it for everyone.
Oh, okay. So the question was, can you speak to the role of probiotics for C. diff prevention? I mean, I think that's still an area of controversy, to be honest with you. And I think C. diff in general is an area where the more we learn, or the more we understand, the more we learn, the kind of the less we start to understand. But probiotics certainly have been shown to have benefit in some meta-analyses. There's some randomized controlled trials looking at them that have failed to show benefit. However, the patient populations in some of those trials may have been poorly sought, in my mind, or developed to really show a difference. So I think in the right population, the right patient, it can possibly be helpful. There's in infection control literature, there's certainly some before and after time series analysis type data looking at probiotics in yogurt, for example, for the prevention of C. diff, but I don't think the evidence is all that great personally.
Any other?
Well, a person who's colonized always be PCR positive.
I'll have to repeat it for this.
Yeah, so the question was, would a person who's colonized always be PCR positive? The answer is we don't know. I mean, probably not always, but they can certainly be positive for years, at least for months, but certainly for years as well. And so it really depends on the patient, their gut flora. They're going to have recovery of some of the gut flora, et cetera. So I think there's a lot of patient-to-patient variability on that question, but certainly can be for a very, very long time.
So that we cure these active cytotoxins, those patients that have active diarrhea.
Well, so most of the institutions or hospital-based laboratories, I think, across the country have gone to PCR testing because of the availability and increased sensitivity, and the fact that you can get answers typically within a day if they're doing them all at the same time. So really, I don't have a firm statement either way on what we should be doing as far as testing, but I think that's something that there'll be more and more evaluation of moving forward, is what is the most appropriate way to test. Currently, if you wanted to do the toxin test, for example, at our institution, that would be a send-out test. That would take some time to come back, so you would kind of lose the ability to diagnose that in a rapid time frame. But certainly, if you had a patient, for example, like one particular I've seen in clinic, where you have somebody who continues to come back for C. diff, but you're not sure if it's their C. diff or their irritable bowel disease or inflammatory bowel syndrome or something, and they keep getting repeatedly treated or not responding, in that situation it might be worthwhile to try to send out a toxin EIA test to try to differentiate what the etiology is. But as far as using the toxin EIA to guide therapy in the initial standpoint, at least empiric therapy, the turnaround time is probably not good enough right now.
Question from Atlanta: how do antibiotic timeouts play into preventing C. diff infections?
Do you want that one? Yeah, I mean, I think it's another area where there's we really don't know. I mean, I think antibiotic stewardship interventions in a bundled approach are very helpful. I can't necessarily speak specifically for antibiotic timeouts, but the goal, of course, of antibiotic timeout is to reassess and just have a reminder to reassess the patient and hopefully de-escalate therapy. So anecdotally, it certainly makes sense, and you would hope it would have a significant impact, but I don't know specifically, looking at that intervention by itself, if it's been looked at or not. You know.
I'm not sure. I mean, I think that duration of therapy does perhaps play a role in a c.diff, and I know we looked at for several studies in decrease in duration of therapy and to see whether or not there's difference. We never saw a statistically significant difference, but also even sometimes one dose of antibiotic can cause c.diff in patients. So it's really hard to tell. I'd hope globally as we decrease use of antibiotics that and durations that may help.
Would it be a reasonable outcome in future studies to look at maybe a way to justify costs and things associated with new rapid diagnostic tests as we're subsequently decreasing antibiotic exposure and maybe reducing the risk of c.diff?
Yes.
I would say yes. That certainly can be a benefit, especially when we're talking about some of the specific broad-spectrum agents like cephalosporins, fluoroquinolones that are putting patients perhaps at higher risk for c.diff. So probably broader you go, more you alter the gut flora, you probably ultimately can impact c.diff and cost. There's the problem with rapid diagnostics, there's so many things to look at it. So I think when you start collecting data, as some have done that, it's very hard to look at just one aspect of it. But at least I think none of the studies have so far looked at the c.diff, which would be particularly interesting with the escalation of therapy.
So knowing that the therapy can take like 2 hours to get a result, is the policy at Johns Hopkins that the pharmacist gets both the grams being called and the being called at the same time, or is it separate? What kind of is the process?
Okay, so the question was at Johns Hopkins Hospital for gram-positive results for Verigene, what is the role, I'm understanding, from microlab to notify the pharmacist or stewardship team, correct? So when we implemented Verigene, which was 2013, like around this time, we didn't have a good way to have a notification. Our clinicians get notified for positive blood cultures. But our microlab, because we have about, in this year period, about 1,000 patients that we perform the Verigene. So it's we have a lot of gram-positives, and so we have large IV population, IVDU, a lot of immunocompromised patients, and obviously a lot of coordinating staff. So it was unrealistic that they would call us or the team for every test that was performed for a Verigene. And so what we did, we utilized Teradoc alerts that kind of generated an email. We tried pager, but it was too much. So we didn't really have a good system to alert us. And so what we have thought clinicians, because we do have a pretty extensive restrictions, so when we approved the vancomycin for GPC in clusters, we told them in 3 hours check out for that test. And then we also kind of did look at those results in a few hours. So mainly what we relied is an email alert that still wasn't done in real time. So if you got page and notified clinicians up front, that time might have been even better. But we did the best what we could kind of in real life, and we utilized our residents on-call program to do that in evening hours and weekends. So it was a kind of an email alert where everybody went to this in basket and just looked at those alerts quickly and ran the patient. So sometimes maybe by the time I look at the patient might have been a few hours. So unfortunately, that's a real life, so we wanted to model what really does happen in real life and understanding that you're not going to always be page, and our microlab can page clinicians for every positive results. They do call only for positive blood cultures because that's a critical value.
All right, thank you everyone for coming, and I appreciate your patience with technology. I know it caused our meeting to run over, so thank you all for staying, and thank you to our remote sites. Remember, at least here we're going to have a raffle for some gift cards, and I'm going to end the webinar presentation. Thank you again.